What's going on, everyone? Thank you all for showing up. This apparently is the hottest club at FMX. We got people standing. We have everyone sitting down, paying attention. I want to thank you all for showing up. We are talking about obstructive sleep apnea. According to studies, about 30 million Americans suffer from this. That might not be encapsulating everyone. You all, as family medicine doctors, are the cornerstone of preventative care, public health awareness, and are integral in the screening and treatment of this patient. So we are honored on behalf of Medscape Live in this news report that you're all here. And I'll just say, that might as well just be a picture of me. So my wife says I snore, so I feel like I'm personally invested in this conversation with our experts. A few housekeeping things. I want to make sure that everyone is paying attention to the slides and asking questions and scanning this QR code. You can chime in. We have an expert panel. We'll have time at the very end. You'll be able to view slides, access content, ask questions, participate in polling, and all of it. We want to make sure that people get a chance to participate. The Wi-Fi information is up there as well. It's speedy, I promise. I'm going to go backwards. Here we go. So introduction, my name is Alok Patel. I'm a pediatric hospitalist at Stanford. I work for ABC News. We have plenty of children with sleep apnea. I talk a lot with my outpatient colleagues. And in my job in medical journalism, we talk about sleep apnea all the time as we're getting more awareness about how this is debilitating. But enough from me. I would love for my brilliant, brilliant co-moderators and faculty to introduce themselves.
Hi. I am Anisa Das, and I am a professor of medicine and pulmonary critical care and sleep at The Ohio State University. Thank you for having me.
Thanks for being here. Can you all keep a straight face while wearing the Minnie Mouse ears? Is the question. I don't know.
No.
Okay.
but maybe we can remove them now.
Yeah. I'm keeping it. Should I keep it? All right. The audience wants me to keep it. Sorry.
I'll get professional just for a second, at least, Alok. So I'm Joyce Lee Ionati. I'm a neurologist, and I do both stroke and sleep at Barrow Neurological Institute in downtown Phoenix, and really excited to be here with everyone. Thank you.
And I'm Safia Khan. I'm a family physician and sleep specialist. I'm an associate professor at University of Texas Southwestern Medical Center in Dallas. I'm also the program director for the Sleep Medicine Fellowship, and my special interest is sleep disorders in women.
So we basically have the Avengers of sleep medicine and managing sleep apnea, which is phenomenal. Thank you all for being here. You know, one thing that we all know is seeing a patient, getting that clinical vignette. So why don't we start with the video from a patient before we move into more analysis by Dr. Das.
Sorts of other medical issues that could derive from sleep apnea. And so having those discussions with whoever could be potentially diagnosed or has recently been diagnosed, it's worth reducing that stigma. And honestly, nobody cares if you use a CPAP while you're sleeping. There's nothing wrong with that. No one's gonna say, oh, wow, what's wrong with you? Right, they'll care if you don't, right? My wife will care if I don't use a CPAP now.
I'm gonna agree. I don't think my wife would care either. But Dr. Das, if you could tell us a little bit more. Let's go through a clinical case about this. Are our slides frozen?
All right, I think they might be.
My momentum is not frozen, just the slides. Don't worry about it.
Let's see if somebody else's are working. Hang on, let me see if mine works. Okay.
There we go.
I got it.
We're back.
I was given access. Okay, so this first case is going to be about an over-the-road truck driver. And if you're not sure what an over-the-road truck driver is, those are folks who do long distance. And Walter came to me after, unfortunately, he got in a really bad car accident. He was a 34-year-old gentleman. He has COPD, so chronic obstructive pulmonary disease. He had been in a motor vehicle crash, didn't realize what happened, but he was told after the fact, dude, you fell asleep behind the wheel. So he recovered from his injuries and was sent to me in sleep medicine. At the time, his vitals were relatively normal. His oxygen stats were on the lower end of normal, but they were normal. He's a tall guy, 6'2". He has a body mass index of 32. So he is obese. And when we talk about his background, and I'm just going to wait for just a second so they can close that door, hopefully. There we go. There is a 40-pack-year smoking history, so he's an active smoker. When we listened to him, the only notable thing really was that he had distant breath sounds bilaterally, and his blood gas, and we'll talk about why this is important. So his blood gas showed a PCO2 of 45, which is considered normal. This is important because if he was a chronic respiratory failure patient, so elevated CO2 levels, it was significantly elevated, we would be treating him a little bit differently. So he's not at that level. And there's his x-ray, and you can look, he does have some hyperexpanded lungs with a little bit of flattening of his diaphragms. Let's see if I can get this going now. There we go. So we did an assessment of screening for him. And this is an assessment for sleep apnea. It's a stop-bang assessment. And I'm not sure if I'm allowed to ask this, but I'm going to do this because I didn't ask. Can anyone tell me if you guys ever use a stop-bang in the audience? Can you raise your hands? Is that allowed? Look, I just did if it wasn't, so there you go. All right. So this is a great screening tool. It's a very high sensitivity, although, as we all know, when we have a test with a lot of sensitivity, what are we giving up? Specificity, right? So stop-bang is 8 questions that are yes or no. Snoring, do you have tiredness? Has anyone said you stop breathing in your sleep? Do you have high blood pressure? Are you treated for that? Is your BMI 35 or greater? Are you 50 years old or older? Is your neck circumference 16 if you're a woman, or 17, and this is in inches if you're a man? And are you male? And so when you look at this, is actually only 3, which is considered intermediate risk. So in a patient who has not just had a car accident, who's not necessarily sleepy, and who otherwise is not considered high risk from a symptom standpoint, you might not jump on a score of 3. But this guy just got in a car accident. He's a safety-sensitive profession, right? He's a truck driver. So for him, we're going to pay more attention to that.
Are there other scores that you use or scales?
Yep, there absolutely are. There are other ones that can be a little bit more complex. For him, the reason we chose this is because it's so sensitive. It's also been validated in truck drivers and shown to be extra sensitive in that population as well, in part because it identifies some objective findings. So truck drivers may not necessarily come to you and say, I'm tired and I snore. They may say that they have less symptoms because they have a little bit of they know that if they have symptoms, there's many more steps, and they're worried about being able to be on the road and make their living. So it's really important to assess truck drivers using objective findings. So the next step, once we decide, okay, we do think that he needs to be evaluated, is to decide which of the 2 tests should we do. So we have home sleep tests, and we have in-laboratory sleep tests, and those are called polysomnograms. Home sleep tests are really good for patients who are high risk. They're good at ruling in sleep apnea, meaning if you've got it, we'll rule it in. They're not as good at ruling out sleep apnea. So to say you definitively don't have it if you're high risk, right? So this guy is somebody who I know is a little bit high risk because he just got in a car accident because he fell asleep. So for ruling out, so you could do it, but if that did not show sleep apnea, then you would have to do an in-lab study to confirm it, right? The upside of these is they're much cheaper, they're easier to do. So a home study might be reasonable for a lot of folks, but if it does not show sleep apnea and you really think that they're high risk for moderate to severe sleep apnea, that's a patient who should then go to the lab afterward. An in-lab is a gold standard. You can definitively rule in or out sleep apnea, but it's a lot more expensive. So we don't always go there first because it's cumbersome, it can take longer to get into the lab.
So Anissa, maybe I can ask you a question that I get often, is specifically in COPD patients on oxygen, can we still do a home sleep study?
No, it's an excellent question. So in general, the patients who should not have a home sleep study are patients with significant pulmonary disease. Anybody who's on home oxygen probably should not have a home sleep apnea test because they may also have overlapping hypoventilation or other things. Additionally, the other patients that we don't use is heart failure patients, right? So a patient who has heart failure, or I would even argue a patient who is very high risk for central sleep apnea because the home studies are not as well validated for central sleep apnea. So for this gentleman, we had two reasons that we chose to do the in-lab. The main one was COPD, right? So if he was a standard truck driver, I probably would have just sent him to a home study first. But because of the comorbid COPD, his baseline stat of 94, we decided to pursue an in-lab sleep study. So let's just talk about COPD a little bit and sleep apnea. So there's some things that actually protect us against having sleep apnea. So COPD patients tend to have a lower BMI, right? They tend to have lung hyperinflation. What does that mean? So an elevated FRC means when I breathe out, I still have more air in my lungs than the average person, right? Because those COPD patients air trap. So that positive air helps then to open the airway. So that's protective. And then because they're not sleeping well, they tend to have decreased REM sleep or dream sleep. And REM sleep or dream sleep is when sleep apnea tends to be its worst, because we really just breathe predominantly with our diaphragm muscles, and we have decreased muscle effort in our other skeletal muscles. The things that promote sleep apnea for COPD, cigarette smoking causes increased inflammation in the airway. And then the skeletal muscle weakness can make us hypoventilate and higher risk for sleep apnea when we do get it. And then some of the medications, like the corticosteroids, can cause weight gain, and that can affect it as well. So we do a sleep study, and on the right, you can see what we refer to as the hypnogram. At the very top, it tells you what stage of sleep, and the black bars are REM sleep or dream sleep. And then underneath that is body position. The next line is the events, apneas or hypopneas. An apnea is if you don't breathe for 10 seconds or longer. That's one apnea. A hypopnea is if you drop your airflow by 30% or more and you have a significant oxygen decrease, whether it be 3% or 4%, depending on the criteria you're using. So this study was used using the 4% criteria. And then if you go down to the red line where it's SaO2, that's looking at his oxygen. And I want you to look at something specific here. So not only is he having the most events in REM sleep, which we talked about, right? That's where our bodies are paralyzed with the exception of our diaphragms. We tend to have the most sleep apnea. But in an average person, so let's say if it was me who was having sleep apnea, I don't have COPD, I might have more events in REM sleep, but you would see the oxygen bounce back up to baseline in between. If you notice, he has these oscillations in his oxygen, but he never quite recovers back up to the 90s. That's because he has overlap syndrome, COPD with a little hypoventilation in REM sleep and sleep apnea. So basically your oxygen drops even more than an average person with sleep apnea. So COPD and OSA can make each other worse in that sense. Okay, so his apnea hypopnea index was 23, so 23 events per hour. That's considered moderate sleep apnea. Mild sleep apnea is 5 up to 15, 15 to 30 is moderate, and 30 or greater is severe. His oxygen nadir was 62%. And then I'm gonna have you also look at for him, his time spent under 88% was 137 minutes. That's pretty significant. I don't get, like as a pulmonologist, 5-10 minutes doesn't really stress me out, but 137 minutes, that I'm gonna pay attention to. This gentleman does not necessarily need oxygen, he needs to breathe, right? So what I'm gonna do is I'm gonna say, well, this guy is probably not the best candidate for some therapy straight away. Okay, so here's what we can think about for treatment. And I'm gonna go through this quicker, and I might let you go through this in a little bit more depth, but for him, we chose to use PAP therapy. Oral appliance therapy wasn't good because maybe for a truck driver, I want to get him treated right away. It can take a longer time to get on it. Surgery, again, is never really considered first-line therapy. And while we might talk about weight loss, again, for him, because of his symptoms, he needs to do something more significant. So for him, we were going to do PAP. A lot of patients can do auto-titrating CPAP. So it's adjustable. I set a range. It senses when you stop breathing and snore, and it adjusts throughout the night, every night. That's great for a lot of folks. But let's think about his hypnogram. He desaturated in REM sleep. I really want to make sure I'm taking care of that, and I want to make sure that his oxygenation is normalized. So for him, we decided to have him come into the sleep lab and do a CPAP titration study. In that study, he got titrated up to a pressure of 14 centimeters of water. On that pressure, he had an apnea-hypopnea index of 4 per hour, which is normal, so that's great. But then you should ask another question as you're looking at that. You'd say, well, if you remember, he only had events in REM sleep. So what if he just didn't have REM sleep, right? Well, have no fear, I'm a good doctor. I looked at it, right? So REM sleep was seen on that pressure, and we know that even on that pressure, he didn't have events. So I know that he was controlled in REM sleep on 14 centimeters of pressure. I also know for this particular gentleman, his oxygen was really good on that as well. And I didn't mention this, that although he had hyperinflation on his x-ray, he did not have significant bullous disease, right? So he did have some COPD, he did not have a bullous disease. So this is his download. I will tell you, if you're working at a big academic center and you have access to sleep providers, we probably take care of this for you. So once a patient's ordered CPAP and I put the order in, I ask the medical supply company or DME to link me to their device. So I actually have remote access. They could call me, they could have a problem, I could look at it. If you're practicing in a more remote location and you're ordering home studies and you're ordering the CPAP and you're ordering auto CPAP for patients, you can ask the DME to give you access to this. It is so easy, and you can make sure things are working well. So I'm just gonna point out a couple of things that we look at. At the very top is adherence. So this gentleman used it for the last 3 months for 100% of the time, and for at least 4 hours, 98% of the time. So that's pretty good adherence, which is important, especially because, again, truck driver, right? And then his pressure set at 14, and his residual apnea-hypopnea index, so meaning on this pressure, his apnea-hypopnea index, so they perceive it, is perceived as 1.1, which is considered controlled. So I know he feels better because he tells me he's feeling better. I know he's using it, and I know his sleep apnea is now controlled. So I've got all that data, so the clinical outcome along with that.
So before you move on, Anissa,
if I let go, it's gonna go. Let's see if I can go back. Okay, go.
So you can also see average hours of usage, and that's another thing that we as sleep physicians look at.
Yeah, absolutely. So this guy's sleeping 9.5 hours almost. Well, no, let me clarify. He is using the machine 9.5 hours almost. That's really important. It's not measuring sleep. That's time of use, yeah. Right? So if you see somebody who's using it for a really long time, I often ask, are you wearing it while you're watching TV before falling asleep? And oftentimes you might get that, right? So you want to ask what they're doing.
Anissa, I'm going to ask you one more question.
Yeah.
This patient's not on oxygen, but spent over 2 hours with low oxygenation. Our compliance, unfortunately, it's still a machine, so there's no oxygenation information. Do you follow that up at all in patients who are hypoxic?
Not if he had a titration. So if for some reason you couldn't do a titration study and you had to do an overnight oximetry, then absolutely you would get an overnight oximetry with this download. But that's exactly why I did the titration study, and I wanted to make sure that on this, his oxygenation was controlled. So you need some form of assessment or another. Now that being said, if his COPD progressed or things worsened, I think repeating that along with the download is a reasonable thing to do.
Thank you.
Thank you.
Okay, so real quick, so that we're being a little bit more efficient. So just so that you know when we talk about COPD and OSA overlap syndrome, this is separate from just OSA. Treating their sleep apnea in these patients makes a significant difference in 2 places. So this was a lovely study that was done back in 2010, and they looked at patients with COPD. Everyone had a sleep study. Those who didn't have sleep apnea along with their COPD is the black line, so they just had COPD. That's that top survival curve, right? And then they looked at patients with OSA along with their COPD, and they offered them CPAP. And those who accepted the CPAP is the blue line, and those who said, no, thank you, they were the red line, right? And you can see by treating their sleep apnea, we were able to get their survival curves back to those with just COPD. So you actually are improving survival by eliminating the secondary comorbid OSA. And then on the right, we're also, beyond just mortality, you have an exacerbation-free benefit, right? So you can keep them out of the hospital, keep overall healthcare costs down, and improve their quality of life from that standpoint. Okay, switching, yes, sir. Yeah, I think so. Alok. We have somebody's asking if he can ask a question. Okay, so yeah, sure, submit into the portal. Okay. Okay, OSA, and then I think I just have 2 more slides and we'll be able to move on. So we talked about this gentleman had COPD. He's also a commercial truck driver. So I do want you to know that crash risk among individuals with OSA, this is not just among truck drivers. This data, actually, this meta-analysis was done among all drivers. So they looked at all studies that looked at all drivers. You have a higher likelihood of getting into an automobile accident if you have OSA versus not having OSA. And that range was between 21% and 389% higher odds of having a car accident. So significant increase of risk there. And then you might ask, well, okay, that's fine. Are you sure? But does CPAP fix it? Yeah, in fact, it does. CPAP in almost every study showed that there was a reduction in that risk by treating their sleep apnea. Okay. So we talked about COPD overlap syndrome. We talked about daytime sleepiness and auto accidents, but just sort of briefly talking about all the different things that sleep apnea can affect in our health. So we know that there's a bimodal relationship between diabetes and sleep apnea. There's a higher prevalence among both. Untreated sleep apnea and sleep deprivation for that matter, actually can make us less sensitive to glucose, and we have higher glucose spikes. Gastroesophageal reflux disease is worse at night among untreated sleep apnea patients. Absolutely cognitive impairment, and there's growing literature actually with Alzheimer's disease and sleep apnea. There's some associative data for cancer suggesting that there's a higher prevalence. That's probably very early. I would not say that it's tied, but that's an area of growing research. There's very good data on showing increased work absentees, so we can improve our workforce attendance by treating sleep apnea. And there's a bimodal relationship with obesity. So there have been studies that looked at, can you treat sleep apnea and make people lose weight? And the answer is no. But what we do know is it's this cycle, right? So I gain more weight, I have more sleep apnea, I'm more tired, I'm more sedentary, I gain more weight, right? It's this constant cycle. And then in addition to that, untreated sleep apnea makes ghrelin, which is the hormone for hunger, go up. So it increases ghrelin, and it also makes us resistant to leptin, which makes us feel full. So we're getting a double whammy, and it's just making us hungry all the time. So we know, like, in those senses, it can make a difference. All right. And then I wonder, in the interest of time, do you want me to just keep going? All right.
You do you, boss.
All right, I'll keep going. I can talk forever, so giddy up. All right. So the other thing is it can affect our quality of life, right? So it affects mental health, being constantly sleep deprived from untreated sleep apnea. Having your spouse constantly do this all night long can affect our mental health, right? It's associated with vitality, so quality of life scales are decreased with untreated sleep apnea. There's actually some cool data about pain control, and pain scales. So sleep apnea via sleep deprivation can not only make you perceive your pain worse, but your actual pain responses are different, and you have increased nerve excitation from when you're sleep deprived versus when you're not. And then physical functioning, memory recall, the ability to speak apparently, cognition. So all of those sort of softer points can also be affected. All right, and I'm done.
Dr. Das, thank you. I want everyone to think about your experiences with patients who you suspect have sleep apnea. Bury that in your head, because I got a couple questions in a sec. We're gonna recenter the room with a quick video, and then I have a question. I'll start dancing if there's no video.
Americans, with around 80% of moderate to severe cases remaining undiagnosed. If an Airbus A340-60 airplane contains 340 passengers, about 30 people on board would have OSA. Of those 30 passengers, 6 passengers' OSA would have been diagnosed, and the remaining 24 passengers' OSA would continue to go undiagnosed. Untreated OSA increases cardiovascular, metabolic, mood disorder, and mortality risk, with up to 70 to 80% of individuals having at least one physical or psychiatric comorbidity, including hypertension, coronary artery disease, stroke, type 2 diabetes, obesity, depression, and anxiety. Adults with multimorbidity plus untreated moderate to severe OSA reported significantly worse physical and mental health scores than those without OSA. Primary care is the front line in OSA screening. Because it's often hidden behind other diagnoses, taking a closer look is advised. Patients report exhaustion, inability to focus, strained relationships, and reduced work performance. Among middle-aged adults with insomnia, over 30% have undiagnosed sleep-disordered breathing. Prompt diagnosis and treatment with CPAP or oral appliances can lower blood pressure, improve glycemic control, reduce depression scores, and cut cardiovascular events by up to 30%, leading to improved survival and quality of life. OSA is common, serious, and treatable. Recognizing it early can transform patient health trajectories. Let's not miss this diagnosis.
I heard the emphasis on primary care in that video. Just saying. So show of hands, who has screened a patient for sleep apnea? Oh, this table's fire. I'm gonna come down to you. I just jumped off a stage, didn't I? Can I ask someone at this table, how do you screen for OSA? You're smiling, so I'm coming to you, Andy.
Either the stop bang or the Epworth Sleep Scale.
Right on. Does anyone do anything different than that at this table? What about how do you screen for sleep apnea?
I use stop bang also.
Does anyone screen with symptoms on its own and suspect it, or do you go straight to the scale? My man. He read it. Now I have a follow-up question. What documentation do people use, or what do you need in order to actually get a sleep study? Someone at this table?
I feel like we should take that.
Usually they fuss at me for a neck circumference, weight, those types of things.
Right on. Neck circumference, weight, anything at this table, the documentation that you might need to get a sleep study.
Daytime sleepiness.
Excessive daytime sleepiness. I'm coming to you. I love family medicine doctors.
Mallampati score also, when you look in their throat, if you can't see anything back there, you got to assume that they have sleep apnea.
Alongside the symptoms and everything.
Hello, can I tell them what I have, because I'm the one who evaluates when they order studies at OSU, and tell them if it gets through or not?
I think you already are telling us. Hit it.
So, and we had talked about it, it's a little bit different regionally, but there's only, so for at our institution, ultimately, if you just have snoring, snoring's not going to get a sleep study covered, unfortunately. You have to have enough symptoms. So for us, you have to have, at least at the Ohio State University, you have to have either sleepiness as an ordering diagnosis or observed sleep apnea as an ordering diagnosis, because if it's negative, we need something that's billable. And then, so that's baseline. You have to have that. And then beyond that, all those things that you guys said were excellent, right? So we need to know all the risk factors. Medicare, some Medicares, Medicare Humana, right now requires that you have a Epworth score and you have a neck circumference in your note. So those are really good things that you both pointed out. But it has to be, 2 points for you. But it's important to have those key symptoms in there.
Right on, and we'll get into later on some barriers, because we have to make sure that our screening and our treatment have an equitable aspect also. But let's move on. Dr. Lee Iannotti, can you talk to us about, I love the title of your section, by the way, with the silent risk from not so silent sleep. Kind of sounds like a horror movie we're dealing with here, but please, take it away.
All right, so let me see if this works. Okay, perfect. So switch gears now to stroke, not COPD, but what an amazing case, and I learned a lot too, Anissa. So I'm going to start with my patient, Michael. Michael is a 51-year-old right-handed gentleman who developed sudden onset of left facial droop, slurred speech, and left arm and leg weakness. As you can see, his vital signs, he's afebrile. His blood pressure was markedly elevated, which we often see in the acute stroke, whether it's ischemic or hemorrhagic setting. But who knows, Michael could have had elevated pressures before coming in. And his heart rate was 72 with no signs of AFib. Additional measures, his BMI is slightly elevated at 28. And on exam, he had an upper motor neuron left facial weakness. If you really want to impress your neurologist, use upper motor instead of lower motor. And so upper motor is where it's sparing of the forehead and it's all lower side of the face. Whereas with Bell's palsy, you're going to get a lower motor neuron left facial weakness. And then left hemiparesis, more in the arm than in the leg. And then dysarthria, which we all know is slurred speech. So his NIH stroke scale score, which is a score between 0 and 24, was only a 4. That's considered kind of on the borderline of mild to moderate. And so he had a notable stroke coming in. I'm just going to pause because I do love the awareness of sleep apnea, but I also love the awareness when it comes to stroke. And we have a lot of work to do in that category as well. So this is the FAST, but there's a new kind of mnemonic that we're teaching patients, which is be fast. So it's a little bit longer by 2, but it also really reiterates that time is brain. So B is balance issues. E is eyes, so either a visual field cut or even double vision or even blurriness of the eyes. F is facial asymmetry or drooping. A is arm weakness. S is speech difficulties, whether that's dysarthria or aphasia. And then T is time. There is so much more that we can do now if the patient presents early. And luckily, Michael had the intuition, his family did, to call 911. He came within less than 3 hours of his symptom onset, and he qualified for tenecteplase, which, if you don't know, it's the new alteplase, which was TPA. So most comprehensive stroke centers, like mine, have switched to tenecteplase for many reasons. One, because it doesn't require a bolus. And we use kind of lower dosages than the cardiologists do. So we use 0.25 mg per kg, whereas cardiologists are using more at 0.5 mg per kg. And we can give it up to 4.5 hours. And believe it or not, there's new literature where we can actually, in clinical trials, where we can actually do a thrombectomy up to 24 hours. Remember when we were cut off at like 3 hours for thrombectomy, then we went to 6, and then we went to 8? So now even patients with favorable perfusion imaging who wake up with their symptoms can qualify for a thrombectomy. And I really live for those Lazarus cases that come in completely paralyzed on one side. They get tenecteplase, they go to our angio suite, and they walk out of the hospital. So I'd love to really reiterate that. Yes, thanks for research, right? And all the science for that. So this is an MRI scan, and this is called a diffusion-weighted image, and it really relies on movement of the water molecules. And anything acute, at least within the first 72 hours, is going to show up bright. And what do you see there? So he has left-sided symptoms. It's on the right side. And the brain is all about real estate. You can have a really tiny stroke, but if it hits the internal capsule, that is high real estate. That is like San Diego, okay, for your motor symptoms. And so that's why he came in with all those motor symptoms. And usually the cause of this is small vessel disease. And the way I explain it to patients is really tiny arteries, the caliber of each of your hair, get clogged up with cholesterol, right, and atherosclerotic disease. So we followed the Sampras trial, and so that's dual antiplatelet therapy, low-dose aspirin and Plavix 75 for at least 90 days, and then usually you can pick monotherapy after that. Atorvastatin and losartan. We love our ARBs and ACE inhibitors. And then he undergoes outpatient rehab and stroke follow-up, and actually gains a lot of recovery in that left arm. At follow-up visits, his blood pressure looks amazing on that low dose of losartan. His LDL is 80, hemoglobin A1C is 5.0, and he's completely compliant with all medications. However, 8 weeks later, he comes back to my hospital with acute worsening of his symptoms. Same side, left-sided weakness again, and now he has sensory symptoms on that side. When we really dig in, we're like, what is going on here? Michael's doing everything right. His blood pressures, all his vitals look good. It turns out that we had missed the most important thing. Most important, I'm biased, right? But obstructive sleep apnea. So please, go ahead.
Is there a timing after the first stroke that we need to be aware of?
First 90 days after your seminal stroke, patients are at highest risk for having another stroke. So in theory, for some of you who do inpatient hospital work, my vascular neurologists do, we should be asking when they come in with their stroke. Actually, we should be asking even before that for primary stroke prevention. And so the earlier we can intervene within that 90 days, Safia, the more benefit the patients are going to get. Thank you for that question. So I'm going back. There's a lot of repetitive slides, but it's really to seal the deal in terms of which patients to screen and which patients to refer, et cetera. So I'm going to take a moment, and if you haven't already, I want you to do the stop bang in your head. Run it through yourself, your partner, your loved one who you think has sleep apnea. And if you have a 3 or above, you should at least get a home sleep study. Home sleep studies are typically covered by your insurance, or if people are paying out of pocket, maybe $100, $200 at most. And we have so many home sleep studies. The last time I checked, we have over 20 devices that have been validated through white papers. So Michael's, as you can see, was a 5. He snored, he felt tired, he had stoppage of breathing noted by his wife, he is older than 50, and then he was a man. So if you have a score of 5 or above, then you have a 90% chance of having moderate to severe sleep apnea. And all the literature shows that if your apnea-hypopnea index is above 15, like Michael, you're at risk for heart attacks, for cardiovascular disease, and also for strokes. So treatment options for sleep apnea. First line, I want to step back and say I'm so happy to see more tools in our toolkits for sleep apnea. We used to just have CPAP, right? Whether you're claustrophobic or not, it was one shoe and you were trying to squeeze it onto everybody. And we felt like enforcers. But now there's more therapies. But I do want to reiterate that all of the other ones are still considered alternatives. So PAP therapy is what we chose for Michael, what we typically choose for stroke patients. And there are ways, if you partner with your sleep specialist, we have little tricks. I use the fear technique because I'm a stroke neurologist. But we have ways to kind of help them. And we do follow them with different mask settings and using sleep sedatives if needed until they can acclimate. And even lowering and adjusting the pressures or even the mode of therapy. But I'm just going to quickly, because Anissa talked about this, but I want to go into a little bit more detail, and I know Safia will too. So oral appliances are great. Find a really good dentist near you and ask your sleep specialist. I prefer that they're certified, they're diplomats of the American Academy of Dental Sleep Medicine because they've gotten the training, they know how to read sleep studies, and they are willing to not only look at the anatomy and turn away as many patients as they take, so they are very selective in their patient criteria. For me, I'm kind of an old school. So until the data shows otherwise, I typically send patients who are closer to normal BMI because we know that the higher BMI, the abdominal girth area especially, they have increased work of breathing. So just targeting the upper airway may not be enough. And then mild to moderate sleep apnea. Although the caveat is it depends on the quality of your dentist too, just like the mechanic. I've seen severe sleep apneics go down to even mild or even normal HIs. So the dentist is really key here.
It's worth a try.
Yeah,
It's worth a try.
The
Absolutely.
literature would say up to 35% of patients can get into the mild range with severe sleep apnea. So while I wouldn't do it as first line, I have a very low threshold in a patient who's non-adherent to say, let's do an oral appliance.
Absolutely.
Because you know what? That's a way better than not treating it, right? I think we have to not put our head in the sand and say, you have to use CPAP, you have to use CPAP. If they can't use it, let's find another option.
And the only two contraindications, and they're relative, are if patients are edentulous, they don't have teeth, but some of our dentists are actually putting posts in where it can anchor in the oral appliance, or what we call the MAD device, which are mandibular advancement devices. And then, TMD. If they have severe temporomandibular disorder or joint pain, it can potentially worsen it, but there are ways that the dentist can work in slowly advancing it before.
And Botox injections as well.
That's right, for TMD, absolutely. So really quickly on surgery. If you watch the Super Bowl, you probably saw every 6 minutes a commercial from the hypoglossal nerve stimulator company. It is definitely a viable option, But we typically reserve it for patients who have failed other therapies, the non-invasive therapies like CPAP, BiPAP, or an oral appliance. You have to have moderate to severe obstructive sleep apnea. Typically, even though the indications have gone up to a BMI of 40, I'm a little conservative and I still like to see a BMI less than 45.
And to be clear, the data is not good for the BMI over. Like you said,
Yes, it's not.
The original data really was for a BMI of 32 and under, and that's because it was better, more efficacious in that group.
Agree. And I think I said 45, BMI less than 35.
Yeah.
But do know that this is still a surgery. I mean, the surgery itself takes 1 hour, it's elective, patients go home on the same day, it is under general anesthesia, but they do have a generator that's implanted that is now MRI compatible, but it actually stimulates the cranial nerve 12, which is the hypoglossal nerve, so it forces the tongue forward when patients have hypopneic or apneic events. When it first came out, I thought, I'm from Arizona, so I thought people would look like rattlesnakes all night. But it's actually really subtle, and it works beautifully in my stroke patients who I've tried CPAP, and they have such facial weakness that I just cannot get a seal with a facial mask. And then lastly, behavioral modifications and medications. This is so exciting. GLPs are the thing, right? And there's a triple G coming out, but it was actually validated for moderate to severe obstructive sleep apnea. By the FDA approved in January of this year, but we're not seeing the effect with insurance quite yet, fingers crossed. But the paper, the seminal paper that came out was SURMOUNT-OSA in moderate to severe sleep apneics, and that came out in NEJM in July of last year, and it showed a significant reduction in AHI, even in our severe sleep apneics. There are more medications, really exciting. One that is coming out, which is a combination of atomoxetine and aeroxybutynin that has shown a lot of favorable outcomes as well. So look where we've come. Just in the 15 years since I've done fellowship, we've already quadrupled the amount of treatment options that we can offer our sleep patients. So those that are discouraged, please still send them. We will work with everybody. Okay, so I'm gonna try to hurry up now, not to run in your time. So Michael's diagnostic journey, his home sleep study, please ask me, why did you do a home sleep study on a stroke patient? They are now validated for the most part, okay? Those are still ongoing, but Michael did really well. His NIH was just a 2, so he'd be perfect for a home sleep study. If I did an in-lab study on him, I'm waiting for at least a month, right, to get him in, and time is brain. So I'm gonna go quickly for a home sleep study, set him up in my stroke clinic at follow-up. It's really cool. The new technology gives you surrogate markers of sleep time versus recording time. So you can see he's actually not sleeping as much as he thinks he is. And he's getting less REM sleep than he should at 14.4%. Normal amounts are 15 to 25%. He has moderate sleep apnea, which means he stops breathing 18.8 times per hour. It goes up in REM sleep because when you're dreaming, your mind is active, all these muscles are relaxed, and people tend to snore, especially women. Sophia's gonna talk about this, particularly in REM sleep. And his O2 nadir was 86%, but it was transient. So he compensatorily kind of is able to recover himself, unlike Anissa's patient. So I started him on auto CPAP. And I love the wide range to help patients acclimate really low, but allow them to go really high. We did do a few mask adjustments in the clinic, and he was fully compliant on therapy. So if I could just take a minute to show you the compliance report on the right side, I do refer to this as a report card, in essence. Anissa's was 90 days. Just so you know, insurance only requires a 30-day before your visit with either you or me. And it does require greater than 70% compliance for more than 4 hours per use. And that breaks down to 5 nights per week, but that 4 hour. And I do clarify the 4 hours because I've had patients misunderstand and they set their alarm at 4 hours and they're like, oh, time to take it off. No. The minimum is 4 hours. And the more you use it, the more benefit you get. So you could see Michael is a rock star, 97%, using it for 7.5 hours. We adjusted. We actually found that he was telling us that he was actually suffocating when he first put it on and realized that he needed higher pressures. It's still a machine, right, guys? And so the machine is going to take some time to find that pressure. And for about an hour, he had trouble sleeping because he was like, I want more air. So we brought it up, slept much better. His median pressure is at 10.6. His max is 15. So he never kind of ceilings out at 20 centimeters of water. We allowed leaks, that other line on the bottom, up to 24 liters per minute. And you could see it's 1.6. So we found the Cinderella shoe with just a nasal mask, which was awesome. And his apnea-hypopnea index went from 18 to 1.3. I've never seen a 0. In the 16 years of practice, if they have sleep apnea, I've never seen a 0. I'm still promising my patients a $100 bill, whoever gets that 0. But have you guys seen a 0?
Under 1. I've seen under 1, 0.2, 0.3. Yeah.
Okay. But never a 0, right? It's not just me.
Never 0.
2?
2 patients with 0.
Wow.
But notice I know them, right? Because it's so rare. So to your point,
so rare.
Yeah, they're rare.
Okay. And what I do love to do too is I love to put like an A+ on their card. And they bring it, I've heard they bring it back to you guys. And they're like, look, my sleep doctor said I have an A+.
I'm gonna steal that.
It works. Okay, really quickly, because producers tell me, hurry up, Joyce. So this is data. It's an oldie and a goodie. And this is from Martinez Garcia in Spain. Did a prospective study in almost 100 patients, looked at CPAP tolerant versus CPAP intolerant, and over 18 months looked at patients who had recurrent vascular events versus those that didn't. 1 stroke in the CPAP compliant versus 7 in the non-compliant group. And this is a Kaplan-Meier curve showing how many people had recurrent events and fell off the wagon. And those with CPAP, it takes some time to work, okay? So on average, for symptoms and for efficacy, it's gonna take about 2 or 3 months. So they had an initial drop, but then they completely plateaued, while those not using CPAP fell off the curve. Okay, I'm gonna go a little forward, and maybe I'll reiterate this one. There's a lot of association between stroke and sleep apnea. And so it is bidirectional. When you are suffocating at night, you are in fight or flight mode, like you're running away from a bear. And so what happens is we see fluctuations and turbulent blood pressure at night, which is actually more disastrous than chronically elevated blood pressures. We see an emergence of atrial fibrillation in our in-lab studies all the time. We see tachybrady rhythms, and then we see worsening of CHF and even neuroinflammation with increased accelerated atherosclerotic disease in the carotids and even intracranially. Okay. For the sake of time, I do want to say that there are other associations that you may not be aware of. So your patients who come in with refractory glaucoma, with AIO1, which is ischemic optic neuropathy, there's a strong association with untreated sleep apnea. NASH is another one. Refractory GERD, Anissa talked about, really important. The take-home point is, please, you're helping me see these stroke patients. Please screen them with us. It is really beneficial in the early periods, not only to reduce the risk of stroke, but also help them rehab. And they have more energy, they have more and better cognition in order to do the rehab. And that ultimately benefits them further down the line. So I want to empower all of you. There are not enough sleep specialists. We're a relatively new field. And unfortunately, this number of 80% has not changed since I did fellowship 16 years ago. There are still so many patients who remain underdiagnosed. I invite you to align with your sleep specialist. And all of us are happy to put you in touch with them and find people you can refer to. And we are happy after you get screening, maybe a home sleep study to take over and manage these patients, because I know you are already doing so much in your clinic and the hospitals. So ask the stop bang. The majority of you already are, and telehealth. I know that's a big question right now. Please ask about sleep. You can do the stop bang, but even asking about snoring and hypersomnia, which are the 2 diagnoses you need for a home sleep study, is enough. Establish relationships with us. And then I do want to, just for the last second, really highlight sleep fellowships. Sleep medicine is multidisciplinary. I have had at least 3 family medicine fellows in the 5 years I've been sleep fellowship program director. They are amazing. You guys know patients through the lifespan like none other, and they were my superstar fellows. It's a 1-year fellowship, and then you can screen and you can read these sleep studies and follow patients through, just like Dr. Khan. And please be aware of health disparities. African Americans are at twice the risk of Caucasians of having sleep apnea in the severe range. And based on the Hispanic Community Health Study, less than 1% of participants who are Hispanic are asked about sleep apnea, when their prevalence is double than that of other ethnicities. Thank you so much for your time.
I'm gonna be quick in the interest of time, but I want people to think about unusual presentations of sleep apnea. Pediatrician hat on. Sometimes kids present with irritability, poor school performance. No one suspects sleep apnea. Who has had an unusual presentation of sleep apnea in a patient? I'm gonna pick on this table right now.
I think hypertension that just is recalcitrant to treatment. That's a very common thing.
Common one.
Severe bruxism in pediatric patients.
I love it. Wow.
Good, that's a good one.
Give me a fist bump. You over here, sir.
He gets 2 points too.
Chronic headaches and depression due to sleep.
Thank you.
Lack
of sleep. And how do people manage some of these chronic conditions in their patients? Hypertension, bruxism, depression. Anyone have a thought about that? How you're managing some of these chronic conditions associated with sleep apnea? This brilliant table.
Maybe a CPAP machine?
Maybe a CPAP machine! What about over here? How are you all managing when you see something like isolated hypertension?
Same thing.
I like that. Listen, consistency is brilliant. Anyone else have a thought about how you're approaching?
I've had a child with teeth broken in half from the bruxism, and so we did the mouthpiece and the CPAP.
Nice.
Gosh. Further proving the point that primary care is where it's at in catching these conditions. Dr. Khan, let me just turn it back to you to send us home with another case, this time, different scenario.
Thanks, Alok. But let me tell you about the most unusual pediatric patient I saw with sleep apnea. It was a child who would turn homicidal if he didn't use his CPAP. Like every morning he would wake up and he'd be like, I'm gonna kill my brother. I'm gonna kill this person, kill that person. And so her parents came in begging that please get a sleep study done, get him started on CPAP as soon as possible because his old machine had broken.
Whoa.
Okay, with that.
Because it's literally life or death.
Literally life and death. So let's do a show of hands. How many of you take care of patients that are perimenopausal? How about menopausal? Okay, and how many of you wonder, how can I fix their fatigue after you've done like $1 million workup, nothing came back abnormal, maybe low vitamin D? We're all checking vitamin D, right? So here I'll walk you through a case of a Korean lady, and she comes in with complaints of chronic worsening of fatigue. You can see that her vitals are normal, her labs are normal, and maybe a tinge of elevated blood pressure, but otherwise, you know, nothing abnormal that stands out. But she does have excessive tiredness, she has brain fog, she doesn't have the energy that she used to in the past, and she could get a lot more done. Now she's struggling with her daily activities. And so she thinks she's in perimenopause because she hasn't had a period in 8 months yet. And you know when menopause starts, when you haven't had a period for a year. But perimenopause can be much prolonged. Perimenopause can start 7 to 10 years before menopause actually starts. So she is frustrated that her PCP is not prescribing hormones, which worked well for a friend. So she came to you asking for hormones. And she's got all these vague symptoms. She did her friends told her hormones worked. She also did her homework, and she asked Dr. Google, and better yet, ChatGPT. And she was informed that hormones are the solution to her problems. Hormones will solve her fatigue, hormones will solve everything for her. So, and she's not just asking for estrogen and progesterone, she also wants testosterone, and why not cortisol? So her friends are doing great on it, right? So being the detail-oriented physician that you are, You ask her about her sleep, and she's not convinced that she has sleep apnea, and that's the cause for her fatigue. So now you have to help her understand what's going on. And she eventually agrees to do a sleep study, and here are the results of the sleep study. You can see that arrow pointing to moderate. So on her sleep study, it does show that she has moderate sleep apnea if we go by the Medicare criteria of 4% drop in oxygen saturation, and severe sleep apnea. So let me tell you about the severities here. So you have mild sleep apnea when you have more than 5 to less than 15 abnormal breathing events an hour. Moderate sleep apnea when you have between 15 to less than 30 abnormal events an hour, and severe sleep apnea when you have more than 30 events an hour. And believe me, we've seen like 150, 60, even 200 events an hour. So some patients can have severe sleep apnea, but we're talking about somebody who's not that severe. And she's not convinced that she has sleep apnea. And she says, well, even if I do have sleep apnea, I don't know. I don't want to start CPAP therapy. So you go over the other options for treatment. She may be a good candidate for weight loss. She may be a good candidate for oral appliance therapy. So you have to start the discussion. If she had mild sleep apnea and no comorbidities, no treatment would be an option. But guess what? It does progress to moderate and then severe sleep apnea as we grow older. And then surgery, hypoglossal nerve stimulation, or if they have large tonsils, take those tonsils out. If they have a very floppy soft pellet or uvula, that can be taken out, although now studies show that sleep apnea can actually come back within the first 3 to 5 years after UPPP procedure. So we don't send them for those procedures. But all the options are listed here, and my colleagues did a great job of going over these options. So now, what you're going to do is talk to her regarding treatment. She still doesn't believe that she has sleep apnea because she says her husband doesn't hear her snoring. But then husbands don't hear. That's another issue. They have a hearing problem.
Selective hearing, right, Safia?
Yep. So how are you going to convince your patient that she should go for treatment for sleep apnea? You are going to do some reasoning with her. At least that's how I partner with my patients. I show them what sleep apnea does and what happens in menopause and perimenopause. Perimenopausal women can have increased visceral fat, and so even if their BMIs are not huge, they may still have increased risk for sleep apnea because they have increased visceral fat. The estrogen and progesterone levels are not what they used to be. Estrogen and progesterone both have a stabilizing effect on the upper airway dilatory muscles. So when you take out estrogen and progesterone, then your airway is more collapsible, and that's why women will say, well, yeah, I think ever since I had menopause, my snoring has gotten worse because I've gained weight. But, well, actually, yes, you have gained weight, or maybe you haven't gained weight. It's also the collapse of the airway because of lack of these hormones. So abrupt hormonal changes can cause these changes in your upper airway dilatation and patency.
On that note, there's actually a lovely study that if you look at premenopausal women and postmenopausal women at the exact same weight, so no weight change, you go up 20% risk of having sleep apnea just by going through menopause. So menopause is a really big risk factor for sleep apnea. I think you pointed out that it's not necessarily weight dependent. I tell patients, because I'm like, well, no, my weight hasn't changed. No, that does not matter when you go through menopause. Well, that's an additional risk factor. It doesn't matter, right?
Absolutely. Another thing to keep in mind is, we all talk about stop bang score. Women kind of don't fit that scale perfectly. I don't like it for women because a lot of times they're told they don't snore, or the hearing issue is another thing. But so they're told their snoring is very mild, maybe just purring. And then their symptoms are kind of atypical, whereas men present with loud snoring, witnessed apneas, excessive sleepiness during the day, ADHD, a lot of other things that men present with, women will have much milder and vague symptoms. They'll have fatigue, they'll have headaches, they'll have depression, anxiety. They'll have sleep maintenance insomnia or sleep onset insomnia. They'll know that they're tired, something is going on, but they just can't point it. They'll ask for hormones, which I'm not against hormones at all. Hormones may actually be the solution for the right patients, but they're not the only solution. And when your patient has more than mild sleep apnea, you should educate them on the benefits of using CPAPs and other therapies for sleep apnea.
And Safia, I wonder if I can add too with the headache, because I'm a neurologist. There are typical headaches associated with obstructive sleep apnea that are very different from migraines and cluster headaches. So if it is from sleep apnea, and then women will report this, but if you intentionally ask, then it will lead you one way rather than the other. It is headaches that are worse in the morning that typically get better as the day progresses, and that has a lot to do with not only the low oxygenation, but increased CO2, right? The hypercapnia. And that ends up causing dilation of the vessels, you get increased intracranial pressure, but as they wake up, they're able to move the tongue out of the way and exhale the CO2. So that is really key when you ask about headaches, and that's really a nice clue to obstructive sleep apnea. Please,
Absolutely.
go ahead, sorry.
And then we as physicians, we are very clear on these symptoms that are on this slide here. We know what sleepiness is versus fatigue versus chronic fatigue syndrome and chronic pain syndrome. But a lot of times our patients don't read the textbook before coming in. So we have to do the education. When they're presenting with these wake symptoms, ask them about their sleep. And don't just stop there. Go a step further. Get a sleep study done. Talk to them about sleep apnea. Talk to them about the benefits of treatment. Because, let's go to the next slide and let's see what happens when you treat sleep apnea. Your quality of life improves. Your physical functioning improves. Your memory, focus, concentration, your tiredness, your energy levels, everything improves. Your mood improves as well. So when you are seeing your patients for follow-up and they're using their CPAPs, their blood pressure is improved, their blood sugars are improved, give their sleep apnea treatments some credit as well. Remind them that because they're using their CPAPs regularly, all of their other health parameters are also improved. Well, what about compliance? And here, it's not all roses. There's good news and there's bad news. The glass is half full or half empty, it depends on the way you look at it. There is data showing that a lot of patients wean off or self-wean off their CPAPs eventually. What do you do about these patients? This is where we need partnership with our primary care physicians. You see these patients a lot more than we do, and so remind them, encourage them to continue using their CPAPs. When a patient comes in and their usage is very good or good, encourage them, tell them you're doing great. You use positive reinforcement and that really works. And when your patients come in and their usage is suboptimal, like we talked about, you need to have more than 70%, more than 4-hour usage. What about if someone has 42%? What do you do with those patients? Don't scare them, encourage them, because it really...
Unless you're you, then you like to use scare testing.
Yeah.
Yeah. So when you show them that their other health parameters are also improving because of managed or controlled sleep apnea, they're really motivated to use their CPAPs regularly. Or they'll ask you about other treatment options. So partnering with a sleep physician, when you have these challenging patients who are struggling with their masks or who don't like the pressures on their machines, because not one size fits all, like literally. There are different types of machines. There's the CPAP, there's the auto CPAP, there's the BiPAP, there's the auto BiPAP. A lot of types of machines that give pressure in a different way. One may be more comfortable for a certain type of patient, another for a different type of patient. So we have to figure out if this therapy is not working for you, are you a candidate for another therapy? So partner with your sleep specialist in the area. And we can help troubleshoot these patients. And then there are the masks. I don't know why in the videos we always show the full face mask. That's a myth. Most patients do really well on very tiny masks, like the nasal pillows that sit under the nose, the cushions sit under the nose, the pillows go up the nostrils. Other nasal masks are very small. Yes, the full face mask is a very good option for for mouth breathers. I'm looking at you in the room here. Most of you are nasal breathers. So when you're talking to your patients and you see that they're not breathing through their mouth, tell them, hey, you're a nose breather. I don't think you will need a full face mask. You'll probably be okay with a nasal mask. So these are things that you can, use to reduce the anxiety patients have with the CPAP devices. And that's where we need your help. We want you to identify adherence issues, engage your patients in treatment, and then we also want you to know that you are frequently the first point of contact for these patients. When they're coming in perimenopause, like we started with our lady here, and they have vague symptoms, you are the first point of contact. When the $1 million workup comes back, almost normal because vitamin D was low. So do refer them for sleep studies, get the sleep studies done, ask their partners, get the family involved. If a patient says that my husband doesn't hear me snoring, well, we talked about the hearing issue already, but ask the family, look at the impact treating sleep apnea has on improving family relationships. We have a sleep lab in Texas, and their motto is saving lives and marriages, because literally you're saving lives and marriages. Let's see.
And Safia, if I can add too, what some people don't realize is in this mix is the DMEs, right? The durable medical equipment. And they're generally really good, but in our sleep practice, we actually have masks. So when patients come and see us, we can fit them with a different mask, and we actually give it to patients.
So that might be just to clarify, like we can't do that at our institution. So that might be very we are unable to do that. Yeah. Okay. No, but that's okay. That's good to know, right? So we don't have that option.
Yeah. So work with your durable medical equipment company in other places, but I do feel like that is empowering as well to be able to do that.
Absolutely. And I feel like we've kind of given you the information to empower you to go back to your practices and help these patients who have vague symptoms or clear-cut symptoms, help them start on therapy and get better lives. So I want you to do two things for me. One is ask 3 simple questions, especially of your perimenopausal and menopausal ladies. Do you snore? Do you wake up gasping for air? Do you wake up with a dry mouth? And these should indicate risk for sleep apnea. If they say yes to 1 or 2 or 3 of these, then they are at higher risk for sleep apnea and they should be evaluated. And then I want you to take action. I want you to plant that seed, start the conversation about sleep apnea, because trust me, it takes multiple visits of convincing them that they may have sleep apnea, and then they agree to doing the sleep study and starting therapy. Thank you.
Nice job. Alok, I wonder if I can ask a question before we go to the audience. So
we have like 6 minutes. Can we do it after?
Oh yeah, absolutely.
I need to get a show of hands from our crowd. Raise your hand if you have referred to a specialist for sleep apnea. Now, raise your hand if you treat sleep apnea yourself because you don't have the option.
Oh.
Right on. So I'm going to walk back to stage. I'm going to put the microphone around. I want people to tell me, just yell it out, what types of barriers you all face or your patients face when it comes to screening, treatment, or diagnosis. What kind of barriers are you thinking? Barriers. Time. Money or insurance. What's that? Insurance.
Long drive.
Long drive. I feel like that's a big one, especially for my patient population.
USPFT not saying to screen asymptomatic patients.
Oh, screening guidelines with asymptomatic patients over here. Oh.
Yeah.
Tolerance, claustrophobia.
Not having their original sleep study when they change insurance or go on Medicare.
Oh my gosh. My blood pressure just went up. Over here. Barriers. Time. Any barriers? What do we not hit? Denial. What's that?
Lack of specialists.
Lack of specialists. You have one. Concerns about the safety of the filters. There's so many. I was thinking just a couple socioeconomic ones, but anyone? Other barriers?
All those CPAP machines got broken and people haven't been able to get theirs replaced.
Who wants to form a startup with me? What's that? I ain't doing that, doc.
Have you met my patients?
Oh my gosh.
I think
You sound like all my family on the WhatsApp chat. I'm gonna head back to stage because we've got some audience questions, but Dr. Lee Ionati, you had something too.
Well, I wanted an honest opinion about HRT therapy and effect on not only sleep apnea, but sleep in general, because we see that a lot, and I'm sure all of you do.
Yeah, so hormones do improve your breathing by improving patency of the airway. So they may have a role in mild to moderate sleep apnea. We don't have any research, and that's where we should focus, do some more active research studies because we don't have the data. Because another thing is, how do you screen whether a person is perimenopausal or not? It's after they have menopause that they realize, oh, I was in perimenopause, and that's why I was going crazy. Somebody mentioned claustrophobia, and let me touch up on that. When your patients say they have claustrophobia, tell them, okay, we will help you get used to your therapies. We're not going to start a therapy that will not work for you, because if it's just sitting on the nightstand collecting dust, it's not the best therapy for you. So I tell my patients, okay, first day, first week maybe, just put the mask on, don't connect it to the machine. Then connect it to the machine, don't try to fall asleep, watch TV, be on your phone. So gradually, you let your body get used to the mask. It's called desensitization. And we have therapists also that can help with that process.
I have some amazing questions, by the way.
Bring him.
I'm gonna bring them. So this is a question. I might get some eye rolls, okay? But don't eye roll because I've heard this a lot from patients and consumers. A patient suggested using mouth taping before committing to CPAP. What are your thoughts?
So there is physiologic information that if you stabilize the jaw, it will actually stabilize the airway. Here's what we say in our group, however. I don't really want somebody who has sleep apnea sealing their mouth. So we tell folks, why don't you see if you, so I actually get this question probably once a week. Yeah. I'm like, let's see. So it's actually a very good question. And it's because of TikTok, because it's all, no, seriously, TikTok has made this famous.
Running our world.
Yeah. So I tell folks, I would, if you want to know if you have sleep apnea, if you have sleep apnea, treat it properly. It has not been had randomized controlled trials. We have theoretical evidence that maybe it could stabilize something. However, I do have probably 6 patients, also anecdotal, who have sleep apnea, want to use a nasal mask, and they use a single steri strip to help stabilize their jaw and keep their mouth shut. Instead of it as a form of a chin strap with positive pressure. So they have something keeping their airway open. So we only do it with positive pressure.
Right on. Here's a question I feel like might be relatable. How does asthma control affect sleep apnea? Almost like, are we paying attention to asthma control before we're going into?
This is an Anissa question.
I was like, I gave a lecture on this. So it's actually advice. It's a little bit flipped. So asthma and sleep apnea share a lot of common traits. One of the biggest ones is obesity, right? So there's a very high prevalence of sleep apnea in asthma patients and asthma in sleep apnea patients, in part because of that shared comorbidity of obesity. And asthma tends to be the most dangerous, kills us, in fact, the most at night, right? So nocturnal asthma is very, very dangerous. One of the reasons for that, there's lots of reasons, but one of the reasons can be that if you have comorbid sleep apnea and you're causing aspiration, that can cause issues with the airway. It's not actually the acid, it's sort of this, it's actually the reflux. So treating sleep apnea can improve control of nocturnal asthma in patients who have comorbid disease. That was a really long way to say it. Sorry.
That's great. I'm gonna rapid fire 2 more. If a patient with OSA who's on CPAP has lost significant weight, at what BMI or weight loss should we redo the sleep study?
Oh, maybe I'll take a stab. And then Safia, follow up if you agree. Sure. So we get that question a lot, and we actually see a lot of patients who come through bariatric surgery or on the GLP-1s. I will caution, I never promise patients that they can hang up their CPAP hat because it is twofold. And the 2 biggest risk factors are the weight, but also upper airway crowding. And so we call it the modified Friedman or the Malampati score. As you know, it was a score looking at how difficult it would be to intubate a patient and cross-extrapolated for sleep apnea. The tongue is a muscle, and it's not going to change so much even with significant weight loss. And we've done exercise. You can YouTube exercises and measure the tongue, and it doesn't change that much. So the truth of the matter is that if they have a low Friedman tongue position, they lose a lot of weight, there's a good chance that their sleep apnea will resolve. But in studies, it's probably less than 20% of patients, unfortunately. So I tell most of my patients it is usually a combination of weight loss and upper airway surgery that would be curative. What do you think, Safia?
I kind of entertain my patients. I tell them, I ask them what's their goal weight. And if they have been steady at the current weight for at least 6 months, I'll give them the option of repeating a sleep study because they've used CPAP all along. So I'm not afraid that if they end up with sleep apnea, they'll quit using the CPAP. So I'll go ahead, repeat the study. I'll show them, look, your sleep apnea severity has improved, or you don't have sleep apnea. Yes, you can discontinue your CPAP. And patients are happy, I'm happy.
Yeah.
Right on. You know, in the interest of time, we have to wrap it, but please bother them afterwards because there's so many good questions. This touches all of us in one way or another, so I sincerely want to thank you three for coming up and sharing your expertise. Thank you all for joining us.
Thank you, guys.
Please scan the QR code to get some credit, some CME, watch the slides. QR code will show up at some point, but thank you all so much for giving us your time. Go forth and save public health.
Yes. Have a good conference. Thank you.
We have a tradition up here. We take a stage selfie.